We're very happy to have you here at Lurie Children's. I am Carlos Prada, and the division head for genetics, and my partner for the first presentation is Dr. Baker. You guys probably know from clinic and hospitalizations. And first, we want to welcome you all, yeah. And we have, first we want to acknowledge we have a lot of good people here from a lot of different states in the country, so about 10 states, you can see from the map, yeah? So over 80 people is visiting us today to this first conference here at Lurie Children's, yeah? We also want to thank you, our sponsors. So we have BridgeBio, which is our gold sponsor with Moderna, and we have our silver sponsors, HemoShear, and bronze Nutrition. And we have additional supporters, including Soya Pharma, Hinomoto, Cambrook, Garrett Austin, the Paris Purpose, and PKU Foundation, PKU Organization of Illinois. And also we want to recognize our co-host, the Propionic Acidemia Foundation, and all the work they have done to get to us today. Yeah? Well, we have a pretty good schedule for the day. First, me and Dr. Baker will review Propionic Acidemia and Methylmalonic Acidemia. We'll have a break, so we'll plan to get on track and have our break planned for 10 a.m. Then we'll talk about risk assessment and family planning. Maddie Hankins, where are you, Maddie? So we'll learn from Maddie later this morning. And we'll have a talk about caring for the caregivers in breakout session and lunch for adults. Carly, is she here? Abate him? Probably will come later today. And then we'll have a lunch break with kids and have time to have discussions. Yeah? In the afternoon, Caroline Serbinsky. Caroline, she's probably in the other room. Yeah. We'll talk more about natural history registry and clinical trials. And then we'll follow with considerations in nutrition. Ann Kosek, I guess she's also out, yeah? Oh, hey. Yeah. And then we'll have another break, and then we'll talk about emergency preparedness with Brittany Smith, and then we'll have our closing remarks. Yeah? So we'll have a pretty busy day and lots of good talks. Yeah? Now, first I want to talk about our team at Lurie Children's. This is our mighty genetics team, a more sunny day, although we actually got lucky and got a pretty good day today, despite the weather advisory. Yeah? And here are our providers. So we have a talented group of 4 metabolic providers. So myself, Dr. Baker, then many of you have met Erica Bucco, who is our nurse practitioner, and then Dr. Pete Leahy, who also recently joined our practice. We have 4 metabolic dietitians, yeah, and who will be speaking to you guys today. Katie Arduini, who is on call with me today. Then Brooke Kirkjan, who you guys probably saw during the registration downstairs, yeah. And Heather Balsall, who is a very experienced metabolic nutritionist with us as well. And then our dietetic, Adriana Bueno, who helps and is an integral part of our team. Yeah? Now, nurses, so these are people that you interact with them on a routine basis with sick calls, yeah? So we have Kristen Havens, Karen Becker, and Erica Carlson. We'll have another nurse joining our team soon, yeah? And we plan to continue growing the support we can provide during sick call, prior authorizations, yeah? All the needs that our metabolic patients need, yeah? In our social work team, we have Sue. You wanna say hi, Sue? She's a jack of all trades, yeah? And Howard is not here today, no? Yeah. And Howard, who just joined our practice soon as well. Now, genetic counseling, so you guys know Maddie, and also someone that needs no introduction, Catherine. Yeah, you want to say hi? And Catherine Kim, who is the manager for the genetic counseling program here at Lurie. Yeah? And we also have a big clinical research team today. You guys have interacted with Carolyn Serbinsky, who is helping coordinate this event as well, and Mike Sowen. Is Mike around? Yeah, probably in the other room as well. And our clinical research manager is Rachel Katz. Yeah. So we have a pretty good team. Oh, and our admins, yeah. Sally, get us all in check. Aaron Robles is our main admin to coordinate our schedules, and she personally coordinates most of my life. If I don't have it on my calendar, it's not happening. And then Trasana, who is our scheduler for metabolic patients. Yeah. So it's a pretty good team that we put together, and we want to keep growing it for the care of patients with metabolic disorders. Yeah.
Good morning. I thought that starting off the talk, transitioning from our team, we would start with a few case presentations. I apologize ahead of time. I have a little bit of a cold from being on call, so I'll keep my distance and my mask on. But if I lose my voice, I promise it's nothing too bad. Negative COVID test. So some case presentations to get us in mind of how we treat and diagnose PA and MMA. So, and I apologize, hopefully none of these bring up bad thoughts or feelings, but just remind you of how your little one or loved one became diagnosed. So this is a case presentation of how we might diagnose a little one with PA or MMA. A 3-day-old, previously healthy baby, nothing concerned during pregnancy or birth, roomed in with mom, went home with family, was doing great, but now won't wake up for feeds. Problem that you just can't get the baby to latch. The mom's really worried and brought them to the children's hospital. Then there were many, many doctors, many, many nurses, other healthcare professionals taking a lot of labs, stabilizing their little one, and then the little one ends up in the ICU where they're told, we are concerned for a genetic condition. We're consulting genetics to meet you and diagnose it, organic acidemia. Luckily for us, a lot more is happening that before that ever happens is there's a nice healthy 5-day-old baby being called by the pediatrician saying, we're concerned there might be a problem on their newborn screening test. We need you to come meet with a geneticist, a metabolic dietitian, that there is an abnormality on your baby's newborn screen. Parents, I don't want to undermine this at all. This is still very scary, very confusing, a lot to go through. But diagnosis this way helps us prevent that emergency from the very beginning and lead to a diagnosis early on of MMA or PA that we can help manage and support you through. Many of you probably, these are very similar situations that you've been through yourselves, and sort of see how we improve that and make that better for future families to come. So let's talk a little bit about PA and MMA. First off, the terminology, I have had this in clinic before that there's some confusion sometimes that, well, why baby has propionic acidemia, but another doctor said they had propionic aciduria. What's the difference? It's the same disorder, but has several different names based on which biochemical geneticist you're talking to. So I apologize if we always call it something different. If we shorten it to PA and MMA, we're pretty much always in check then. But if you talk to a different metabolic geneticist, we're always calling things differently. And so we also love a pathway in genetics. I know everyone is confused by metabolic pathways, including myself, but it sort of helps us in medicine know that when you have a problem down here, like MA is down here at the bottom, and then right above it is PA, the enzyme to sort of, if you have a genetic disorder in these areas and a deficient enzyme activity, you will have these conditions. That there are many, many steps above it, and then even more after it, to take these amino acids, these organic acids, and take them into energy. So how can we modify the system below, and even find alternative pathways to alter and change this to better medicine? So first, let's talk about PA. So we'll go into a lot more detail about the genetics of PA and the inheritance pattern a little bit later with Maddie. But as you all probably know, it's an autosomal recessive condition, meaning we have 2 copies of every gene, one from mom, one from dad, and you need both copies to be changed or genetically modified to have PA. The incidence, so how common is PA? And the numbers are really sort of changing as we learn more through newborn screening. Previously, we thought PA to be very, very rare, and through newborn screening, we're finding that it to be more common than previously thought. Incidence is changing, 1 in 100,000 to 130,000, but it's going to be different based on different parts of the world and what their newborn screening is finding. We also found through newborn screening that there's various types of PA that we have previously missed. For example, if you think about it, we talk a lot, and many of you probably more familiar with severe PA that presents in the neonatal period or young childhood period, but we're finding more adults even who have, or adult forms of the disorder that probably would have been not screened previously for PA before we enacted newborn screening. In Illinois, we've been only screening for PA for about 20 years, and we'll go through that in more detail as well, but that means that there are any adult 20 years or older is at risk for having milder PA and not being known. So I think this number we're still learning, and it's changing. The enzyme deficient here is propyl-CoA carboxylase, and there are 2 components of it, so 2 different genes that can be changed for you to have PA. The nice thing, though, is if you have a genetic change in one and a genetic change in the other, there's no proof that you will then have PA. From our current understanding is to have severe PA, you have to have the 2 changes in the same gene. You might have some mild abnormality of both. And what we screen on newborn screen is the organic acid C3. So it's just looking for a small carbon structure that you can sort of see here as a structure of PA. So basically, it's a very small molecule that's basically a piece of a protein that the nitrogen has been taken off. And so you're left with an organic acid that your body's using for energy. Methylmalonic acidemia is very similar, and that's why they're sort of combined in all of our organizations, our treatments of the disorder. It's also autosomal recessive. The incidence is changing a little bit more than PA as well. We're finding a lot more as China is introducing newborn screening, and specifically through Taiwan's newborn screening program. We're finding milder forms of MMA to be very, very common in that population, but it's going to be different based on your ethnic background, what your ancestors' genetic changes are. The enzyme deficient here is methylmalonic CoA mutase, so just 1 gene responsible for MMA versus 2 for PA. As you can see here, it's a little bit more double structure compared to PA. The same abnormality is going to be seen on newborn screen and trigger metabolic geneticists to bring you in for evaluation and determination for this disorder and treatment. So let's talk a little bit about that diagnosis program. So newborn screening is vastly how we find majority of patients with MMA and PA. Illinois Department of Health has really set off their cutoffs quite well, that we're modifying this pretty regularly, that they know from their levels and call the metabolic centers if there's a very concerning level, an elevated level that could be concerning for severe PA or MMA, so that we can bring them to the emergency room immediately and do that diagnostic workup. If the level is elevated but not dangerously high, then they are referred to our newborn screening program to do a telemedicine visit with myself or Dr. Leahy or one of our other metabolic providers when we're off to help get those diagnostic labs and evaluate for any evidence. On newborn screening, what we do is check what's called an acylcarnitine profile that's looking for that C3 level, and also looking at the urine organic acids. And I'm sure all of you remember the process of catching urine on a baby is not the easiest thing to do or the fun thing to do, but those urine organic acids, looking for those elevations is key to diagnosing M-A-M-P-A. There's a lot of discussion in the world and through the metabolic and genetic community why don't we start with genetic testing before these biochemical tests? And very interestingly, we find that over half of our patients that we follow from our newborn screening program would have been missed by genetics first. We're still learning a lot about the genetics of M-A-M-P-A, especially from these rare populations that we would have otherwise missed if we started with genetics first. So genetics plus the biochemical testing is really crucial into finding the diagnosis and getting the baby in for treatment. And then we're going to do a little bit talk about genetic testing, but we're going to trade off with me and Dr. Prada.
Okay. So you guys can all take a test now, tell the difference in between the chemical composition of M-A-M-P-A. Yeah. So genetic testing. So we're going to have a talk about genetic testing and family planning and care testing later this morning. But genetic testing is something that is getting better and better over time. As mentioned, Dr. Baker is still not quite there to be the first test for newborn screening. That's why we relied so much on the biochemical studies that he was discussing. So molecular testing, just give us a little extra information about how the specific variability of the Propionic Acidemia genetic variant or the Methylmalonic acidemia happens. Yeah. Sorry, one second, guys. Copy page. So what the spelling of the gene help us know, hey, what do we know about that specific genetic variant? Yeah? Question number one. Question number two, is the genetic spelling change on that gene is predicted to decrease the activity of that enzyme in a more drastic way than another change that is in a different location of the gene. So we look at all of this to know, hey, is that genetic change likely to respond to specific cofactors or not? Yeah. A lot of times we still end up doing what we call the trial of a specific supplement to see if there's a benefit or response, regardless of that specific molecular change. But the goal as we understand better the molecular testing is, can we actually develop new treatments that are specific to that specific genetic change or not? So there's a lot of news you will see about CRISPR and other technologies that are happening that we hope keep coming to the clinical testing. Yeah? Now, for family planning, a lot of the metabolic disorders are going to be recessive, so that's the case for MMA and PA. And basically, we expect parents to be carriers, so asymptomatic, yeah? So carriers have 2 copies of the gene, and 1 copy is working, and that's enough of the job to prevent the symptoms. And then you're going to have a 1 in 4 chance to have a baby that has the disorder that inherit both copies that don't have a functional enzyme either for PA or MMA. Now, the majority of children will be carriers, or also there's a chance that the child does not inherit any of the copies that have the potential genetic markers. So you guys will learn more about this in detail. Now, treatment. Yeah. So there's several steps to treatment. So one is diet, yeah, and we'll learn from the master and later this morning. Oh, this afternoon, after lunch. So hopefully you guys are not in a food coma, yeah? But part of the diet is really modifying some of those, as Dr. Baker presented the pathway, the specific amino acids that really led to the increase of those compounds that are not healthy for someone with MMA or PA. And what we want to do with diet is decrease the amount of those specific amino acids. Yeah, you can see that isoleucine, valine, methionine, and threonine are part of those that we try to avoid, because we want to decrease the production of those compounds that your body cannot process. Yeah, so that's the first step in management modifying your diet to prevent that. Yeah? Now, we also use supplements. So one of those supplements is called carnitine. And carnitine basically has several roles and functions. One is a way for our body to use fats and use energy, because carnitine is a transporter too, and just helps things flow across different parts of your body. If you look at inside your body, in the cells of every organ, this is very important for trafficking and use of energy. Also, carnitine is something that makes things more soluble. So that means all the toxic compounds we have been talking about today of the propionic pathway really bind carnitine to be excreted in the urine. Yeah? So that's another reason why we like to supplement it. And as the kid grows, we're going to increase the dose. Yeah? You see this example, we use 150 mg per kilo per day. And we use this during the healthy days and also during emergencies. And that's why carnitine is a drug that gives us a lot of opportunities, because it's also IV. So if your child is not tolerating feeds, we can switch this to endovenous, so then there's no, we don't miss that opportunity. Yeah? Now, the other medications you guys are familiar with is carglumic acid. Yeah? Why do we use carglumic acid? Because there's another compound that gets very high in some of our patients with PA and MMA that is called ammonia. Yeah? And ammonia is something that can be toxic for your brain. Yeah? So we want that number to go down. In patients with MMA and PA, Dr. Baker put here a picture of the urea cycle. The urea cycle is what breaks down the ammonia and is excreted out of your body. Yeah? So in patients with PA and MMA, we have what we call a secondary block on that pathway that makes it really difficult to process the ammonia levels. Yeah? So carglumic acid, what it does is kind of replenish some of those missing factors. Yeah? And help kind of restart the urea cycle so you have less accumulation of ammonia. Yeah? And that's the reason why we use this in the treatment for PA and MMA. And this is the dose that we have typically used here at our center. Now, emergency. So this is something we do in the hospital, but before we talk about emergency, what's really important is that you guys trust your team, yeah, and we have an open communication. So that means if you feel you're struggling at home, yeah, we want to hear from you before you're calling us that you're going to the emergency room. Yeah? So that's sort of like the first step. So call your medical team, not necessarily when things are bad, just when you feel like, hey, you know, we were not able to finish the formula that day, or we have fever, or we have something going on. And we'd rather have the call to kind of have a brainstorm and plan to prevent that you end up in the emergency room. Now, once you call us that you're going to the emergency room, we also like to be able to notify the emergency room that you guys are going. Yeah? So emergency rooms are very busy. Yeah? And so that little extra step helps us know, hey, we can try to advocate to get you not necessarily fast track, but it just helps to tell what we're looking for and what labs we do need to do. You guys have an emergency letter that our team provides that explain. The idea with the emergency letter is to try not to put you on the spot of explaining what your diagnosis is and what your child needs, is just to help that being taken off your plate. Yeah? And then we do the fluids and the lipids and the ammonia medications we just mentioned today, with the goal to get those numbers down as soon as possible. Yeah? So that's our goal with emergency management, but also our goal is that by what we're currently doing in clinic with diet management and ongoing communication, we hope to prevent that you guys have to come too much to the emergency room. Yeah? Now, research. So you guys are going to learn a lot of research today, and we have a talk with Caroline as well about clinical trials and natural history studies. Yeah? And you have also our sponsors today, that many of them are doing clinical trials. So that's a very exciting time for patients and families with propionic acidemia and organic acidemias. So, so here we have a picture of a lab, yeah, but I think the questions really come from the clinic, yeah. So, and parents and physicians and scientists. So this kind of go back and forth in between what we think is relevant, what we can do in a lab in terms of studying a disease, and how we can actually return that information to families to develop better treatments. Yeah? So we are at a critical point that there is a lot of understanding of the PA and MMA pathways, and there's a lot of new ideas of how we can modify some of those pathways to prevent that the child has complications. So that's where we're currently working on, trying to identify where can we make improvements in diet, where can we make improvements on admissions, when can we make improvements in overall health and complications related to acidemia propionica and methylmalonica, or methylmalonic. I'm gonna go in Spanglish today, yeah. And but we have lots of ideas and good people, and that's why we're here today, just to show our interest and our partnership with you guys to try to make this better together, yeah, for patients with M-A-M-P-A. Now, I'm gonna let Dr. Baker talk about gene therapy, yeah, and some of the other future approaches, yeah.
So this isn't, we just want to take the time today to kind of review that gene therapy aspect, because we know that there's a lot of information in the news, Grey's Anatomy, everywhere talking about gene therapy, and want to sort of review that aspect, because we believe that PA and MMA is one of the areas that is going to sort of rapidly advance, we think, in the use of gene therapy products in one day. And want you as the families hearing this information to understand what are these therapies trying to do, and what do they sort of look like. So this is taken from the FDA website on gene therapy. They have a very nice video that talks a bit about gene therapy that's probably better than I can explain it, but it's like 15, 20 minutes long, so I'm gonna give you the Cliff Notes version of what is going on here. So in clinical research trials and different sort of aspects of therapy, there are a few gene therapy trials that are FDA approved as well, but most of the work is right now in clinical trials and bench research. There are two different models. Ex vivo is a way of alternating or changing the genetic information outside of the body. So it's still changing genetic information for cells, but that change happens outside of the body, not within the patient. In vivo is within the body, so doing gene therapy, giving that genetic change to the patient directly. And we'll talk about the advantages and disadvantages of both. But so ex vivo, historically what's been a lot of the sort of research and aspects of gene therapy ex vivo has been hematopoietic stem cells. So taking stem cells from the bone marrow, taking them into the lab or sort of research center to change the DNA either by protein modification or infecting those cells with a virus to deliver genetic information. This then allows the lab to filter out which cells have that genetic change and which ones have not had the change that we're really looking for. So we give back the bone cell sort of transplant to patients that have that genetic change. This is a really big area for different sort of therapies for disorders that affect the bone, like sickle cell disease, or some other sort of treatments, that aspect. It's a bit harder to get enough cells changed for PA or MMA that's going to affect the body by doing a bone marrow transplant this way. The other way to do this that's more investigational is, can we take these stem cells from a liver, modify those stem cells from a liver in a lab, and then give them back. So those stem cells then locate themselves within the liver, grow, and produce those change. The benefit of doing this outside of the body is you don't have as big of a reaction by doing it within the body itself, the immune response. You still have to give some immune modifying medications to get the body to accept those new cells that are coming in. But since they're the patient's own cells, you don't have those toxic effects of getting like a bone cell donor from an unrelated person or from like a cord blood. So if we use your own cells and give them back, the thought is the body's going to see that as their own cells and accept those a little bit better. But it's very, very hard to get a number of cells to have a significant change. Because if we change even just a small fraction of those cells, it probably won't be enough to have a large impact of the circulating PEA and MMA levels within the bloodstream and within the cells. So more and more therapies are looking into the in vivo approach, which is how do we target a virus most commonly to then change that genetic information of a liver cell to help it process and break down the PEA and MMA. The hard parts there are, once again, you're giving an external sort of virus, so it's a lab-made virus that isn't going to sort of then create an illness within that patient's system that then they're going to infect other people, but your body still sees it as a virus and has its own sort of response like you would getting other viruses. The gene therapy sort of companies and investigators are working on how do we modify the immune system so it doesn't sort of break down those cells that were infected and doesn't fight that infection as much, so you don't have as much of those symptoms, but it's still a possible side effect and concern we have to look at. Also, we're not very good at this route of infecting the stem cells. We're really good at taking and putting that virus into the liver cells, but if those liver cells eventually die, they're going to be replaced by cells that don't have that genetic change within them. So this route changes the stem cells. This one is much harder to change the stem cells. So we get stuck in this path of what is the best for PA and MMA as we move forward. Is it a short-term aspect of fixing it for a while, or a more robust way of finding a way to boost these cells and get more permanent, sort of long-lasting fix? Again, I think there's a long way to go with gene therapy, but I hope this sort of explains some of the science and reasoning why we're doing what we're doing in the gene therapy research. And we are ending with that part into our question and answer session, so that, especially something so complicated with that, if you have questions or concerns, we can discuss those now. So Dr. Prada will come back up and join me after he answers this page, and then we will sort of answer any questions you have before the break. Questions, comments, concerns? Compliments are also taken. Yes.
Cash and
Yeah.
do you have a microphone?
Yeah. Yeah, I think a lot of different, from my understanding, there's a lot are moving forward with phase 1/2 trials, which will be safety aspects. It really depends on what that gene therapy aspect, on what that safety data looks like. If those would then move to phase 3-4 trials, that takes 5-10 years to do. So I think we're still decade, if not decades, before something is FDA approved, but it's something that still is going to advance once we have those aspects. It depends on how we can also steal the science from other disorders. If you find one that works well, don't reinvent the wheel. Take that's working for PKU, for example. If we find something that works for PKU, modify it so that it works for PA and MMA.
Mm-hmm.
So
Yeah.
each group has their own organization. Europe has their own sort of regulatory group. Since they're smaller countries, there's one governing body that is a lot of all of Europe. FDA is just the US, but they each have their own rules. And Dr. Prada might be able to talk about other countries as well.
Yeah, no, I think if this regulation across the world regarding gene therapy, and every country is going to be a little different, or community, yeah. But again, kind of the reason why it takes so long is because safety comes first, yeah. So as we plan with any new treatment, we want to make sure there's no harm being made by those therapies. So that's what takes a lot of time for the idea concept to actually implement in clinic, yeah. But also we're talking about rare disorders that it really takes a long time to be able to enroll in those clinical trials, yeah, because it just takes also participation from the community to actually make those breakthrough happen, yeah. So there's a lot that takes. It's not just the drug, the technology, yeah. I think the technology is moving fast, and then the implementation and the barriers to get to that goal is probably something we all have to work together to make it happen, yeah. Now, before gene therapy, we do have clinical trials here open at Lurie Children. So we have one for HST 540, which is when we're looking at the pathway, so there's accumulation of the coenzyme A pool that a lot of the toxic compounds related to M-A-M-P-A bind, yeah. So if we can decrease that, yeah, that may help improve some of the outcomes we have for MMA-M-P-A. So we are part of that trial here at Lurie Children. So we are currently enrolling patients with either MMA-M-P-A. Our team can give you information about that. But there's also other trials that are happening at our institutions. There are other coenzyme A pool compounds that are being looked at. And there's also mRNA therapy that is very popular because of the vaccines for COVID, yeah. And before COVID, we were all looking at potentially using this technology for MMA-M-P-A, yeah. And I know there is information also from our sponsors today regarding their trial, yeah. There's different technologies, all with the thought that this may help overcome some of those blockades, yeah, in your metabolic pathway, yeah. You have a question there, yeah?
Oh, could I just ask you to ask your question in the mic so everyone can hear? Sure. Yeah, so you mentioned about the carglumic acid. Is that something that we can use at home too on an ongoing basis? Because we're not using that right now. So is that something still in the you said it's FDA approved, so is that something that we can approach our doctors and ask them if we can implement it in our treatment?
Yeah, so we can talk about carglumic acid. So carglumic acid recently got indicated for PM and MMA. It was actually developed for a different indication, yeah, a much rare disorder in the urea cycle pathway, yeah, which is very, very few patients worldwide, yeah. But so we used to treat the hyperammonemia in a different way for PM and MMA, but it did not necessarily fit the mechanism for why, yeah. So we thought carglumic acid makes more sense from the actual metabolic pathway to use during episodes of hyperammonemia. So that's sort of the current indication. Now many of patients still have elevated ammonias, not just during the acute setting, yeah? And that has been sort of our practice to try to use this medication to lower the ammonia, even on a daily basis, if we don't have good control, yeah?
Any side effects related to using that?
Yeah, I will say too before that not every patient has the ammonia concerns, and so if your doctor isn't recommending that because there's not the high ammonia concerns, then that might be why as well. A lot of side effects we see are if you start it too fast, too high, like many of our other medications, you get a lot of the GI side effects. So some GI irritation, some diarrhea along with it is the most common that we see. And so we typically start a little bit lower and increase it to avoid some of those side effects, but that can happen with the carnitine as well. We see it with a lot of our medications.
Yeah, and with the gene therapy, do you have any known successes so far? I know you still, have you, even in the animal models, or have you seen any successes?
Yeah, not within, not that I'm aware of with PA or MMA that's been quite successful within the lab. Again, that's going back to sort of taking animal models for other disorders. We have seen, especially in some of the disorders that affect the central nervous system, good FDA approval and advancements for their gene therapy. And it's sort of how do we modify that gene therapy to change the liver. I think the liver is a lot harder to do just because the liver regenerates itself so quickly, luckily for us, but it's one that's harder to decide how do we modify that, because even in mice are going to regenerate their liver quickly.
Thank you.
Also, there's a lot of research at the NIH. The Dr. Vendetti's group has been working on developing gene therapy. I think they're making huge advances, yeah, and they're probably at some point going to be moving from that preclinical model to at some point a clinical trial, yeah. So I know that's coming, yeah. Not quite there yet for us to work with you guys on that, yeah.
Sorry, one more question on gene therapy. I sort of see the PA and MMA kids in two different buckets, the ones that have working enzyme and ones that do not. So for gene therapy specifically, is it the same therapy? Would it, be more advanced or for children that have some working enzyme and as opposed to kids that don't have any working enzyme?
Yeah, I think that's a really good question, because some other of our disorders within metabolism, that's one way to sort of help too, that if they have some nice residual enzyme, you don't have to change as many cells to boost up that enzyme activity. Whereas if you have very, very little enzyme activity from a severe change for PA or MMA, it's going to take a lot more cells to move that up. But some of the science and arguments too are, even if we can't make the enzyme level normal, but if we can take it from 0 to 2 to 5%, that's going to be a huge change to the amount of protein they can process. So I see it depends on the researcher, but both ways of where we go with that enzyme activity.
Any other questions?
So I have a question for you guys. What do you guys want to see happening in MMA and PA? Yeah? As parents and families, yeah?
Does someone have their hand up?
To me, it looks like there's still a lot of different paths. Every hospital, every doctor, every country is a liver transplant the best option with its side effects? Is a gene therapy the best option? We're heavy carboglue users, so we have GI problems with our twins. I guess it's good to have a lot of opportunities to follow, but as a parent, we'd like to see this is the promise where we should be going with our kids now, because obviously we don't have decades to wait.
Yeah, so I mean, that's a huge challenge from parents and families and patients. Yeah, who is going to benefit from all this development and when? Yeah, and that actually changed the way we do things at the hospital. Like right now, we really need to maximize protecting brains. Yeah, because we have all these new therapies that have potential. Yeah, but we really want to keep the quality of life and the independence of that child the best we can, yeah, so they can take advantage of what's coming, yeah. I think this treatment is one aspect, yeah. Access, education, yeah. I feel like lowering the bar for every physician to really know what a rare disease is. I think there's a lot of emphasis on that. Dr. Beck is trying to work with the med school to try to increase opportunities at that level, yeah. It's just so much we have to do, yeah. So. But I think in order to really make a difference is the partnership between you guys and us, yeah, to make sure that we move in all fronts, not just one, yeah.
And I do think that there has been a push from different family organizations and physician organizations to work on guidelines and standards of care, because we do realize there's very few metabolic geneticists out there, and each of us may have been trained a little bit differently, that we need better evidence of which is the best standard of care, because a lot of what we do has been, this is our model, this is who taught us, and that's sort of how we pick what we do.
Anybody?
We have twins, identical twins with a PCCB/PA gene, and they just turned 10 this week. So it's a long ways from where we started. I mean, our first conference was, this is what PA is, and we don't have any hope for you. And then to where we are now. So it is coming along.
Yeah. And there's no bad questions, guys. Let's see. We have 5 more minutes, yeah, maybe 3.
Oh. Yeah. So has there been any discussion or thought into looking at gene editing stuff or CRISPR in terms of potential treatments for PA?
Yeah, so there is, so that's a great question. So there is a lot of research in CRISPR technology. I guess the main challenge for how we translate that into clinic is you need to have good delivery mechanisms, like where this is going, yeah, which cells are going to be edited, what you're editing is going to last how long, is this going to have off-target effects. So all of that is what the industry is trying to refine in academia to make it safe, yeah. It's very hard to say we're going to gene edit all your cells, because that's going to require a lot of coordination, but also your body is very smart at protecting you against everything that is foreign. Yeah, so we're still kind of at the beginning of understanding how your body can tolerate all of these procedures. It seems like it's in a petri dish. It seems a little bit simple in a way, but that's good. So can we translate this into practice? Yeah, but when you put it into the context of the human body, that's when we start seeing a lot of unanticipated risks that that may prohibit the use of some of those approaches. Yeah, but there's a lot of smart people working on it, and we hope that as those questions are solved, we're gonna see more of this going into clinic. Yeah.
Thank you.
So if I understand it correctly, there's an enzyme not being produced or not enough of an enzyme in the liver. Has there been any research on trying to introduce that enzyme into the body so it does break down the amino acids?
Yeah. So there is, great question. So there is a lot of research on enzyme replacement therapies. Yeah, probably most of what we have done is in a different set of disorders called lysosomal storage disorders, where we know the body can uptake that enzyme, and the enzyme can go into the right location within the cell to do the job. Yeah. There has not been one for MMA-M-P-A that we can give as an infusion or something like that. Yeah, but there is the different approaches. One is, we talk about gene therapy. One is the other medications, such as the HST540 that binds part of the other downstream of the enzyme. And then mRNA therapy, which is basically, we give you the code for the liver to make the enzyme you're missing. Yeah. So that's the trial that is undergoing with mRNA. Not quite to give you the enzyme, but to give you the message to make the enzyme in your liver, because your liver can make those enzymes. Yeah, just giving you the right message with the right spelling. Yeah, so your body can make it. Yeah.
Thank you.
So do you see any kind of, from the time the patient is first diagnosed to several years down, does the body adapt and maybe change its behavior towards how it processes protein over the period of time? Does it get better? Does it get worse?
Yeah, that's a really good question, because that's some of the, Dr. Vendetti has been putting out a lot of the natural history aspects, and it's something we work very closely with our dietitians, because there's periods of growth and development where the body needs a lot more protein, like in infancy, teenage years. There's other periods like toddler years, so it's very slow growth, where they tolerate less protein. I think that that can be very frustrating for families, because it's a roller coaster of, okay, do we need more protein? Do we need less protein? And it's sort of a constant, if you've seen me in clinic, I let my patients who are very bossy know that they are the boss, and they tell me how much protein their body is processing, and we then respond to that. But it is, over the span of life, changing constantly.
Is that because naturally going, like a person goes through natural developmental stages that the protein processing changes, or it's their body adapting to specifically process the protein better as they get older or worse as they get older?
We think it's more that it's the body's natural response of how much protein they need different times. All of us need different amounts of protein at different periods of growth and development, and likely that blocker enzyme activity isn't changing from that genetic change. It's just more pronounced or less noticeable based on those periods of growth and development.
Okay, so it's not like brain cells that grow, multiply. Your other liver enzyme producing cells don't do the function better or worse as time goes on.
Well, that's you want to apply for a grant for that? That's a great question. Yeah. So there is kind of the routine work cells do, but we actually know there's developmental stages to what we do, and your brain is not fully grown when you're born. Yeah, so you're still undergoing very important steps on myelination, cortical neurons firing to each other and developing more connections. So all that is very critical in the first 5 years, yeah, or longer, yeah. But so there may be some that are just very important stages, but we feel like regardless, there's an ongoing need for all of this. So it's a great question. We probably don't have the full answer, yeah.